Now we are going to discuss the important topics related to general surgery. First of all, we are going to discuss the hospital acquired infection. So what is hospital acquired infection? Is the infection that follows surgery or admission to the hospital. So what is hospital acquired infection? Is the infection that follows surgery or admission to the hospital. One question is asked frequently that what is the most common hospital acquired infection, and the most common hospital acquired infection is UTI. What is the second most common hospital acquired infection? Is the surgical site infection or wound infection. So hospital acquired infection, I told you the most common is UTI. It is responsible for 30 to 40% of hospital acquired infection. The second most common hospital acquired infection is surgical site infection. This is responsible to 50 to 20% of hospital acquired infection. Third is respiratory infections. This is responsible for 10 to 15%. Fourth is bacteremia, and again this is responsible for 10 to 15% of infection. And the fifth is antibiotic associated diarrhea. Antibiotic associated diarrhea, this is responsible for 5 to 10% of infection. So how to remember? The mnemonic is USSR ban. So the mnemonic is USSR ban. So U means UTI, SS means surgical site infection, R means respiratory infection, B means bacteremia, AN means antibiotic associated diarrhea. Question is asked, what is the most common hospital acquired infection? UTI. Now see the twist in the question. Most common hospital acquired infection in surgical patients, and in surgical patients most common hospital acquired infection is surgical site infection. So two important questions are asked. First, most common hospital acquired infection, that is UTI, and most common hospital acquired infection in surgical patients, and that is surgical site infection. Second question, what is the most common organism responsible for UTI? So here the most common organism responsible, and the most common organism responsible is the E. coli. This is a question, frequently asked question. Second, generally in most of, or I should say in majority of surgical infections, E. coli is the organism responsible. In most of the surgical infections, you want to see the example. If you see this simple diagram, this is kidney, this is the ureter, this is the bladder, this is the prostate, and this is urethra. This is the vas deferens, this is the testis, vas deferens, testis. Now I told you most common hospital acquired infection is UTI. So this is urinary tract infection. And what is the organism responsible? The most common organism responsible is E. coli. Now see, via this urethral route, what happens? This organism reaches the prostate. And if the organism reaches the prostate, what happens? If the organism reaches prostate, there is acute bacterial prostatitis, chronic bacterial prostatitis, and prostatic abscess. And for all these infections, what is the organism responsible? Most common organism, E. coli. So see here, Here you can see in prostate, acute bacterial prostatitis, chronic bacterial prostatitis, and in prostatic abscess. In all these three most common organism responsible is the E. coli. Now see, via this prostatic urethra, the infection reaches vas deferens and then it reaches the testis. If it reaches vas deferens or epididymis and then testis, if it reaches epididymis, it is epididymitis, and if it reaches testis, that is orchitis, and if both are involved, it is known as epididymoorchitis. Now see, this is acute epididymoorchitis, and acute epididymoorchitis in children, in elderly, and in homosexuals. What is the most common organism responsible? The organism responsible is E. coli. Now see, whenever this organism via ureter reaches the kidney, if the organism via ureter reaches kidney, it leads to acute pyelonephritis, chronic pyelonephritis, emphysematous pyelonephritis, and perinephric abscess. And in all these cases, most common organism responsible is E. coli. So see here there is acute pyelonephritis, there is chronic pyelonephritis, there is emphysematous pyelonephritis, and perinephric abscess. And in all these cases, the organism responsible is E. coli. So here you can see that in this genitourinary tract, for most of the infections, most common organism responsible is E. coli. Now coming to GIT and hepatobiliary pancreatic tract. Question: E. coli is the most common organism responsible for first cholangitis, second pyogenic liver abscess in Western countries or worldwide, spontaneous bacterial peritonitis in adults, infection in pancreatic necrosis, and anorectal abscess. So these are the questions which are frequently asked in exam. Next topic is surgical site infection. So what is the definition of surgical site infection? It's the wound that discharges significant quantity of pus or needs secondary procedure to drain it. So definition: what is surgical site infection? It's the wound that discharges significant quantity of pus spontaneously or needs secondary procedure to drain it. There are scoring systems for the wound infection or surgical site infection. One is Southampton wound grading and second is asepsis score. So these are very important, nowadays frequently asked scoring systems for severity of wound infection. First is the Southampton wound grading system. This is very important. Southampton wound grading system. And the second is asepsis wound score. Asepsis wound score. These two are very important, and nowadays in most of the exams Southampton wound grading system and asepsis wound score is being asked. See what are the various parameters in these two scoring systems. Now see the details of Southampton wound grading system. It is divided into 4 grades. So see the grade. Grade 0. What is the appearance in grade 0? And after that, there are further subtypes and appearances. Grade 0. In grade 0, there is normal healing. In grade 0, there is normal healing. After that, in grade 1, there is normal healing with mild bruising or erythema. It's normal healing with mild bruising or erythema. Now this grade 1 is further divided into 1A, 1B and 1C. See, further division. 1A. In 1A, there is some bruising. In 1B, there is considerable bruising. Considerable bruising. And what happens in 1C? There is mild erythema. In 1C, there is mild erythema. After that, grade 2. In grade 2, there is erythema plus other signs of inflammation. Erythema plus other signs of inflammation. Now it's further divided into 2A, 2B, 2C, 2D. So see the further division. 2A. In 2A, there is erythema plus other signs of inflammation at 1 point. These signs at 1 point. In 2B, it's around sutures. In 2C, it's along wound. It's along wound. And in 2D, it's around wound. It's around wound. So this is grade 2. After that, see the grade 3. In grade 3, there is clear or hemoserous discharge. Clear or hemoserous discharge. And this grade 3 is also further divided into 3A, 3B, 3C and 3D. So see the further division. What's 3A? It's at 1 point only. less than 2 centimeter. It's at one point only, less than 2 centimeter. What about 3B? It's a long wound and more than 2 centimeter. 3C, there is large volume of discharge. And 3D, it's prolonged. Prolonged means it's more than 3 days. So it's prolonged. That's more than 3 days. Now, what is grade 4? In grade 4, there is pus collection. And this is further divided into 4A and 4B. So what happens in 4A? In 4A, pus is at one point only. It's at one point only, less than 2 centimeter. And in 4B, it's along the wound and more than 2 centimeter. It's along wound and more than 2 centimeter. So this is Southampton wound grading system. From the last 3-4 years, continuously questions are being asked in AIIMS, NEET, JIPMER, PGI from this topic. Now see the criteria of asepsis wound score. Asepsis wound score. So first A means additional treatment. A means additional treatment. Now what are the details of those additional treatment? First, antibiotics for wound infection. Antibiotics for wound infection. Second, drainage of pus under local anesthesia. Drainage of pus under local anesthesia. Or third is debridement of wound under GA. Debridement of wound under general anesthesia. So in asepsis, A means this additional treatment. After that, S means serous discharge. E means erythema. P means purulent exudate. Is the purulent exudate. S, separation of deep tissues. Is the separation of deep tissues. I is the isolation of bacteria from the wound. So there is isolation of bacteria from the wound. And S means stay as inpatient. Stay as inpatient, and it's prolonged over 14 days. Prolonged over 14 days as a result of wound infection. As a result of wound infection. So these are the components of asepsis score. Now see, mnemonic is here, asepsis. So A means additional treatment, S serous discharge, E erythema, P purulent exudate, S separation of deep tissues, I isolation of bacteria from wound, and S stay as inpatient, and it's prolonged over 14 days as a result of wound infection. So Southampton wound grading system and asepsis score, these two are frequently asked nowadays in exam. Now these are the two pictures, and the question is asked which one is erysipelas and which one is cellulitis. Now see how to differentiate. If you see the first picture, can you see here there is well defined margins. So here you can see that there is well defined margins. Clear? And generally it is involving which part? It is involving the face. Now if you see the second picture, in the second picture, can you see the well-defined margins are not there? So this one is erysipelas and this one is cellulitis. First question, that what are the organisms responsible? Actually speaking, in both the organism is same, and that is strep pyogenes. So the most common organism responsible, it is same in both, it is the strep pyogenes. Here also it is strep pyogenes. But rarely Staph aureus can also cause cellulitis. So it can be caused by Staph aureus also, but this is rarely responsible for cellulitis. Second, you saw that here there are distinct margins or well-defined margins. There are well-defined margins in erysipelas, but in cellulitis there is indistinct margins. There is another feature. Generally in erysipelas, if you have seen a case, these patients are having vesicles or bulla. Vesicles or bulla are rarely associated with cellulitis. So this one is associated with vesicle or bulla formation. Vesicle or bulla formation. Whereas this is rarely associated with bulla formation, and this bulla formation is seen in severe cases only. In severe cases only. Now in erysipelas, which part is involved? Generally there is involvement of upper subcutaneous tissue, and lymphatic vessels, and lymphatics or lymphatic vessels. Whereas in cellulitis there is involvement of, be careful, involvement of deeper subcutaneous tissue. Deeper subcutaneous tissue. And you saw what are the common sites of this erysipelas? Is the face with bridge of nose and cheeks. Now see this picture, you can easily identify. Here you can see that there is involvement of face, cheeks, bridge of nose. Can you see? So this is the involvement in erysipelas, whereas in cellulitis the common site is leg. So legs are the common sites. So these are the differences between erysipelas and cellulitis. Now tell me, what is the name of this condition? Can you see here? There is infected mass. So in this picture you can see that there is infected mass. It is filled with pus, dead tissue, and can you see there are multiple openings in the skin. Multiple openings in the skin. So this is what? This is characteristic feature of carbuncle. So this is carbuncle. This is another image based question. So first question, what is this carbuncle? It's abscess with one or more openings. Abscess with one or more openings. And here you can see that there is pus draining onto the skin. Can you see this? So pus draining onto the skin. You have seen this case especially in diabetics, where exactly at the nape of their neck. This carbuncle is caused by which organism? The most common organism responsible is Staph aureus. And what is the most common site? It's the nape of neck. Question, what is the most common organism responsible? It's the Staph aureus. And what is the most common site? It's the nape of neck. Nape of neck. I told you what are the predisposing factors or etiological factors. So see, it is more common in diabetics. So it's more common in diabetics and immunocompromised patients. Diabetics and immunocompromised patients. There are certain triggers of this carbuncle. So what are the triggers? Sometimes there is accidental pulling of hair because of friction, sometimes because of shaving, and sometimes there is folliculitis in immunocompromised patient and diabetic patient, which progresses to carbuncle. So see, in these patients there are various triggers. So what are those various triggers? First, folliculitis, poor hygiene, and accidental pulling of hair. During shaving or because of friction. It's during shaving or because of friction. So you saw the description of this carbuncle. There is infected mass with dead tissue, pus inside, and there are multiple openings over the skin. Can you see? Multiple openings over the skin draining the pus. So see the description or the clinical findings. In carbuncle, there is infected mass, and this infected mass is filled with, pus. It is filled with dead tissue and fluid. What is the appearance? It's red and white. So generally the appearance is red and white with yellow center. Why? Because there is infected mass inside. Since there is dead tissue, there is pus, what we have to go for? We have to go for incision and drainage, plus we have to give antibiotics. How we are going to give the incision? See, suppose this is the mass, this kind of incision is given. So you can see what kind of incision is this. This is the cruciate shaped incision. So this is the cruciate shaped incision for effective and wide drainage of pus and necrotic material. The similar incision we discussed is also given in anorectal abscess. So what's the treatment? The treatment is incision and drainage plus antibiotics. And question, what kind of incision is the cruciate shaped incision? So we give cruciate shaped incision in patients of carbuncle. Now we are going to discuss gas gangrene. This is very important topic, frequently asked in exam. First question, what is the most common organism responsible for gas gangrene? Is the Clostridium perfringens. So first question, what is the most common organism responsible? It's the Clostridium perfringens. Clostridium perfringens. You have seen that there are certain risk factors for gas gangrene. So what are those risk factors? Risk factors. First of all, diabetes mellitus. Second, immunocompromised patients. And sometimes there is wound containing foreign or necrotic material, and this promotes the anaerobic environment. And since Clostridium perfringens is an anaerobe, what happens? It increases the risk of gas gangrene. So see, wound containing necrotic or foreign material. Necrotic or foreign material, and this promotes the anaerobic conditions. these anaerobic conditions what promotes the growth of this Clostridium perfringens. Now there is a typical appearance and there are typical signs and symptoms of gas gangrene. Have a look. Now here can you see this brown colored exudate? Brown colored thin exudate, can you see? Characteristic feature. In these patients there is severe local wound pain. So see the clinical findings. In these patients there is severe local wound pain, and since what is the name? The name is gas gangrene. So there is gangrene with gas. If there is gas in the tissues, if you are going to press, what you have the feeling? You have the feeling of crepitus, and this is the characteristic feature. So this is gas gangrene. So there is gas in tissues, and because of this gas in tissues, what happens? There is feeling of crepitus. After that, what we discussed, that there is thin brown sweet smelling exudate. Thin brown sweet smelling exudate. From the wound. Sometimes there is one-liner question asked in exam. And what is that one-liner question? Myonecrosis is the feature of which of the particular condition? Myo means muscle, necrosis means necrosis. So myonecrosis is the characteristic feature of gas gangrene. So it is associated with myonecrosis. Question is asked, which two features are characteristic here? One is gas and the second is smell. And what kind of smell? Can you see? Sweet smelling. So characteristic features are, there are characteristic features. One is gas and the second is smell. So it's the gas and smell. Now what's the treatment? We have to give large doses of IV penicillin. So here we have to give large doses of IV penicillin, and we have to go for aggressive debridement of infected tissue plus debridement, aggressive debridement of affected tissue. Whenever we suspect that there are increased risk of gas gangrene, it's better to give the prophylaxis to the patient. So how we go for the prophylaxis of gas gangrene? Prophylaxis of gas gangrene. First of all, we have to give antibiotic prophylaxis for at-risk patients. So antibiotic prophylaxis for at-risk patients. Second, we have to give passive anti-gas gangrene serum. So passive anti-gas gangrene serum. Generally this serum is given IM, intramuscular, but it can be given IV in emergency. Generally given IM, but it can be given IV in emergency. And whenever there is a traumatic wound where we can see that contamination is there, the delayed closure of that contaminated wound should be delayed for 5 to 6 days. So closure of traumatic wound, it should be delayed for 5 to 6 days. Delayed for 5 to 6 days. So these are the various measures used for prophylaxis of gas gangrene. Now we are going to discuss tetanus, and you must be knowing that tetanus is caused by organism Clostridium tetani. So it is caused by Clostridium tetani. Now in Clostridium tetani, this organism, what happens, there is exotoxin. What's the name of this exotoxin? This exotoxin is tetanospasmin. Is the tetanospasmin. Now see how it works. This tetanospasmin, it affects myoneural junctions. So it affects myoneural junctions and motor neurons of anterior horn of spinal cord. Anterior horn of spinal cord. Clear? So there is tetanospasmin. This is the exotoxin. Now see what are the clinical features in tetanus. The initial symptoms. What are the initial symptoms in tetanus? There is trismus, that is also known as lockjaw. So in these patients there is trismus, that's also known as lockjaw. There is muscle pain and stiffness. Muscle pain and stiffness. In these patients there is back pain and there is difficulty in swallowing. These are the initial symptoms of tetanus. Now see what is the problem. If in tetanus there is short prodromal period, this short prodromal period is associated with poor prognosis. So in these patients, if there is short prodromal period, this short prodromal period, it is associated with poor prognosis. The patients who are having short prodromal period, in these patients there is spasm of short motor nerves. So in these patients there is spasm of short motor nerves in face. And because of this spasm of short motor nerves in face, it is followed by severe generalized motor spasm. Severe generalized motor spasm. And because of this severe generalized motor spasm, what happens? There is opisthotonus. There is respiratory arrest. And this leads to death. So that's why short prodromal period is having poor prognosis. There is another question related to tetanus, and the question is, what is Rhesus sardonicus? So what is Rhesus sardonicus? The other name of Rhesus sardonicus is sardonic grin. So the other name is sardonic grin. Now what is the problem in this sardonic grin? This is highly characteristic feature of tetanus, and it is characterized by, in this case, there is sustained spasm of facial muscles. So there is sustained spasm of facial muscles, and because of this sustained spasm of facial muscle, it appears to produce grinning. So it appears to produce grinning. So this is Rhesus sardonicus, also known as sardonic grin. It's the characteristic feature of tetanus. So what's the management of tetanus? The best preventive treatment for tetanus is prophylaxis with tetanus toxoid. So what is the best preventive treatment? The best preventive treatment is the prophylaxis with tetanus toxoid. Prophylaxis with tetanus toxoid. Now second, suppose the patient is having established infection. In that case, how we are going to manage? So second situation, the patients with established infection. So in cases of established infection, we have to go for wound debridement. So go for wound debridement. Simultaneously we give benzyl penicillin. Benzyl penicillin. And in certain patients we have to give antitoxins using human immunoglobulins. So antitoxin using human immunoglobulins. This is given for at-risk patients and the patients having established infection. The patients having established infection. So this is how we are going to manage the patients of tetanus. Now see what is the name of this condition. In this you can see that there is necrosis of skin, subcutaneous tissue, and this necrosis is up till the deep fascia. So necrosis till the deep fascia, but underlying muscles are spared, and this is known as what? Necrotizing fasciitis. So this is characteristic feature of necrotizing fasciitis. Necrotizing fasciitis. In this case, what happens is the rapidly progressive bacterial infection. Rapidly progressive bacterial infection. Now how to remember? The name is necrotizing fasciitis. It means the necrosis is up to the deep fascia. So in this case, what are the structures involved? There is necrosis of, it is characterized by necrosis of subcutaneous tissue plus fascia. Be careful, underlying muscle is spared. Underlying muscle, that is spared. So you might have seen these cases in the ward where extensive wound debridement should be done. Extensive wound debridement should be done to save the life of this patient. Now what is the problem here? Question is asked, what is the most common site? It's the lower extremity or lower limb. We discussed similar condition in testes, and that is known as Fournier's gangrene, and that is necrotizing fasciitis involving the perineum. There also we discussed that skin, subcutaneous tissue, fascia is involved. Underlying structures were spared, like testis is spared. So generally, what's the most common site? Is the lower limb. And there is another question which is asked, what is the Fournier's gangrene? What is the Fournier's gangrene? And it's the necrotizing fasciitis. Necrotizing fasciitis involving perineum. So Fournier's gangrene is necrotizing fasciitis involving perineum. One question which is frequently asked, that what is the most common organism responsible for necrotizing fasciitis? Be careful, it's polymicrobial. And here both aerobes and anaerobes are responsible. So it's a polymicrobial infection, and both aerobes as well as anaerobes. So both aerobes as well as anaerobes are responsible. Next question, what is the single most common organism responsible? So question, single most common organism responsible, and it is group A, beta hemolytic streptococci. Group A, beta hemolytic streptococci. What are the risk factors for necrotizing fasciitis? Generally, for these kind of infections, two common risk factors are there. One, diabetes mellitus, and second is immunocompromised state. So see, what are the risk factors? First of all, diabetes mellitus. Second, immunocompromised state. Third, penetrating trauma. Penetrating trauma. Fourth, IV drug abuse. So it is common in drug abusers. Skin infections, skin infection, and pressure sore. Pressure sore. Question is asked that what is the most important presenting symptom? Here patient comes to you. See the picture? Here patient comes to you and patient complains of severe pain. So the most important presenting symptom, most important presenting symptom is the pain. Is the pain. And this pain is disproportionately greater than expected. This very severe pain. Now what is the problem? This is very severe. Now, if we are not going to treat the patient, what is the problem? Sometimes this pain decreases without treatment. Without treatment, sometimes the pain decreases. So question, why this pain decreases? Because afterwards there is thrombosis of small vessels. So pain decreases because of thrombosis of small vessels. So there is thrombosis of small vessels, and after that what will happen? There is destruction of peripheral nerves, and because of destruction of peripheral nerves, pain decreases. Now be careful, if pain decreases, it's an ominous sign. So decrease in the pain, it's an ominous sign. Simultaneously, can you see the appearance of this wound? There is erythema, there is edema, there is woody hard texture of subcutaneous tissue. So here you can see there is erythema, there is edema of the skin, there is woody hard texture of subcutaneous tissue. Woody hard texture of subcutaneous tissue. If you have seen these patients, there are systemic features also. What? Initially there is fever, there is tachycardia, there is hypotension, and these patients might progress to septic shock, which can lead to DIC and multi-organ failure. So what are the systemic features of necrotizing fasciitis? Systemic features, there is fever, there is tachycardia, there is hypotension, and all these can progress to, this can progress to what? Septic shock. It can lead to DIC, and it can lead to multi-organ failure. Multi-organ failure. Now, how we are going to manage? Whenever these patients are coming, we have to go for urgent surgical debridement plus IV antibiotics. So, management, we go for urgent surgical debridement. Urgent surgical debridement. Since patients are having hypotension, what else we have to give? We have to give IV fluids, and patient is having sepsis, so what we have to give? IV antibiotics. IV antibiotics. Simultaneously, apart from all this, we have to provide the supportive care depending upon the condition of patient. Now see the problem. Without surgical debridement, how much is the mortality? It's the 100%. So question which is very important, there is 100% mortality without surgical debridement. And be careful, that's why whenever these patients are coming to us, we have to go for urgent surgical debridement. Question is asked, what is the role of hyperbaric oxygen in necrotizing fasciitis? This hyperbaric oxygen helps in healing of the wound. So role of hyperbaric oxygen. This hyperbaric oxygen is helpful, or it helps in wound healing. So it helps in wound healing. So these are the important points related to necrotizing fasciitis. What is chronic burrowing ulcer? So see, chronic burrowing ulcer. This is one of the favorite topic of NEET and DNB. Frequently asked. First question, what are the various names of chronic burrowing ulcer? This is the question which is asked. What is the Melanese gangrene? So the name is Melanese gangrene. What are the other names? It's also known as burrowing phagedenic ulcer. Burrowing phagedenic ulcer, also known as progressive synergistic gangrene. Progressive synergistic gangrene. So generally in exam it is asked by two names. What is Melanese gangrene or Melanese ulcer? This is one question. Or they asked that what are the organisms responsible for progressive synergistic gangrene? Since the name is synergistic, so obviously it is the synergistic infection. So it is caused by synergistic infection. Synergistic infection of, this is the question which is asked, microaerophilic, be careful, microaerophilic non-hemolytic streptococci. So it's the microaerophilic non-hemolytic streptococci. Non-hemolytic streptococci. This is one organism, and there is aerobic hemolytic staphylococci. Aerobic hemolytic staphylococci. These are the organisms which are asked in exam. So question is asked, what are the organisms responsible for Melanese gangrene? Is the synergistic infection of microaerophilic non-hemolytic streptococci and aerobic hemolytic staphylococci. Sometimes aerobic hemolytic staphylococci is not mentioned, and they mention a single organism. What you have to mark? Microaerophilic non-hemolytic streptococci. Now, what are the associations here? In this case, there is formation of burrowing cutaneous fissure. Burrowing cutaneous fissure, and there is formation of sinus tracts. After that, because of formation of burrowing cutaneous fissure, what? It is going to open at distant sites. Even sinus tracts, these open at distant sites. So these are the characteristic features of Melanese gangrene or Melanese ulcer. Next is tuberculous lymphadenitis. If you have seen tubercular lymphadenitis, generally it is going to affect children and young adults, and what happens is the deep cervical lymph nodes in upper part of neck which are most commonly involved. So see, what is tuberculous lymphadenitis? It is generally affects children and young adults. So most commonly it affects children and young adults. In this, what is the most affected lymph nodes? The most commonly affected lymph nodes are upper deep cervical lymph nodes. These are upper deep cervical lymph nodes. Now question is asked, how this tubercular bacilli gain the entry to these lymph nodes? So via tonsils the lymph nodes are involved. So here the tubercular bacilli gain entrance through the tonsil, entrance through the tonsil. See, this question is actually asked in pathology also, and it is asked in pediatrics also. So see, pathology related questions. In 80% cases, the tubercular process is confined to the affected lymph node. So here tubercular process is limited to affected lymph nodes. Now what is the problem? If we are not going to treat this condition timely, what will happen? In absence of treatment, what happens? In tuberculosis there is caesaceation. So there is caesaceation of lymph nodes, and because of this caesaceation of lymph node, it is going to liquefy and break down, and because of this liquefaction, what happens? There is formation of cold abscess. So in tuberculous lymphadenitis, see the sequence of events. Can you see these are the lymph nodes? So in stage 1, actually there is lymphadenitis. So in this stage 1, there is lymphadenitis. After that, can you see there is matting? So what? The lymph nodes become matted, and after that what happens? There is formation of cold abscess, and see this cold abscess ruptures. What happens? There is erosion at one point in the deep fascia, and because of this erosion, what happens? There is formation of this collar stud abscess, and ultimately what happens? It is going to rupture outside, and there is formation of tubercular sinus. So these are the sequence of events I'm repeating. Initially you can see there is just lymphadenitis. After that, matted lymph nodes are there, then formation of cold abscess, then collar stud abscess, and after that there is formation of sinus. If you have seen cold abscess and you have seen how we are going to perform the aspiration, it should be from the superior aspect of abscess that we are going to aspirate. This is known as anti-gravity aspiration. Why? To prevent the sinus formation. So question is asked, what is collar stud abscess? So in collar stud abscess, actually pus is initially confined. It is initially confined by deep cervical fascia. And you saw in the picture what happens? There is erosion at one point, and whenever there is erosion at one point, what happens? After this erosion, pus flows through the small opening into space beneath superficial fascia. Beneath superficial fascia. So this is collar stud abscess. Question: how we are going to treat the tuberculous lymphadenitis? Obviously the treatment is ATT. So we have to go for ATT. Sometimes the abscess fails to resolve even after ATT. So if there is no improvement or abscess fails to resolve, if abscess fails to resolve even after ATT, in these cases, what we have to go for? Excision of abscess, excision of lymph nodes, and fibrous capsule. So in these cases, we have to go for excision of abscess, lymph node, and fibrous capsule. Now we are going to discuss typhoid or enteric fever. Enteric fever or typhoid. So first question: what is the most common organism responsible for typhoid or enteric fever? Is the Salmonella typhi or Paratyphi? First question: most common organism responsible is the Salmonella typhi or Paratyphi? Typhi or Paratyphi. Question is asked: what is the most common cause of ileal perforation in tropical countries like India? And it's the typhoid. So it's the most common cause of ileal perforation. Ileal perforation in tropical countries like India. Lots of questions are asked about this condition in medicine also and in pathology also. We are going to discuss the pathological aspect and surgical aspect. So first see the questions related to pathology. So what is the problem in enteric fever or typhoid? There is ulceration and necrosis. Ulceration plus necrosis of ileocecal Pierce patches. Ileocecal Pierce patches. And because of this ulceration and necrosis of ileocecal Pierce patches, what's the problem? There is presence of longitudinal ulcers in the distal ileum. So there is longitudinal ulcers in distal ileum, and it can lead to what? Perforation. So this can lead to ileal perforation. And this is the question which is asked in exam, that in typhoid or enteric fever, this ileal perforation occurs during which week? And it occurs during 3rd week. So ileal perforation occurs during 3rd week. First question. What is the second question? What kind of ulcers are seen in typhoid? Is the longitudinal ulcers. In tuberculosis, there is transverse ulcer. Longitudinal means along the axis. Transverse means perpendicular to the axis. So if you see this picture, here you can make out what? These are the transverse ulcers, and these transverse ulcers are seen in tuberculosis. So here there is transverse ulcer. Now see the typhoid. Here you can see there is presence of longitudinal ulcers. So these are longitudinal ulcers. This is the difference between tuberculosis and typhoid. Coming to the clinical features, question is asked, what are the hallmark symptoms? So in typhoid there is pain and there is fever. There is high grade fever. So hallmark symptoms of typhoid. There is fever and there is abdominal pain. Apart from these hallmark symptoms, certain non-specific signs and symptoms are also there. So what are non-specific symptoms in typhoid? So there is headache, there is myalgia, there is arthralgia, arthralgia, there is fatigue and cough. After that, questions are asked, what are the complications of typhoid? Complications. This is very, very important. So first question, what is the most common complication? And the most common complication is paralytic ileus, followed by intestinal hemorrhage. Paralytic ileus followed by intestinal hemorrhage. So it's paralytic ileus followed by intestinal hemorrhage. We discussed that in this case what happens? There is perforation also. So perforation, and again I'm repeating, during which week this perforation occurs? It occurs during 3rd week. Simultaneously, it also leads to cholecystitis. So it can lead to cholecystitis. And you know that chronic typhoid carrier is an indication for prophylactic cholecystectomy and increases the risk of carcinoma gallbladder. Questions are asked that what are the characteristic signs of typhoid? So see the characteristic signs. In these patients, there is presence of rose spots, there is splenomegaly. Be careful, generally in infections there is leukocytosis, but here there is leukopenia with shift to left. Generally when fever is there, patient is having tachycardia, but here there is relative bradycardia. Relative bradycardia despite of high fever. So despite of high fever, there is bradycardia. These are the characteristic signs. The management of typhoid is discussed in detail in medicine. Another topic which is very, very important, especially NEET DNB aims, that is SARS, MERS, sepsis, septic shock. Definitions. So first see what is SIRS. SIRS, full form of SIRS is the systemic inflammatory response syndrome. It's systemic inflammatory response syndrome. First question, what are the mediators of SIRS? The mediators of SIRS are IL-1, IL-6 and TNF-alpha. IL-1, IL-6 and TNF-alpha. So what is SIRS? Full form systemic inflammatory response. So it's the inflammatory response of the body to infectious or non-infectious insult. So it's the body's inflammatory response. Be careful, body's inflammatory response to infectious or non-infectious insult. The question which is asked that what are the various components of SIRS? So there are 4 parameters, and out of these 4 parameters at least more than equal to 2 should be present. So here for SIRS more than 2 of 4 should be present. Should be present. Now what are those parameters? First, temperature, either more than 38 degrees centigrade body temperature or less than 36 degrees centigrade. Second, heart rate, more than 90 per minute. Third, respiratory rate, more than 20 per minute. And fourth, WBC count, either it's more than 12,000 per microliter or it's less than 4,000 per microliter, or there is more than 10% immature cells in peripheral smear. So these are the 4 parameters. Out of these 4, at least 2 should be present. Now see how to remember. The mnemonic is THR counts. The mnemonic is THR counts. Can you see? THR counts. So THR counts: temperature more than 38 degrees centigrade or less than 36, heart rate more than 90, respiratory rate more than 20, WBC count more than 12,000 or less than 4,000, or more than 10% immature cells in the peripheral smear. After that, what is the definition of sepsis? It's the systemic inflammatory response syndrome plus established focus of infection. Established focus of infection. So this is sepsis. After that, question is asked, what is the severe sepsis? What is severe sepsis? So in severe sepsis, there is sepsis with organ dysfunction, and hypoperfusion. Organ dysfunction and hypoperfusion. So this is severe sepsis. After that, what is the definition of septic shock? Septic shock. And this septic shock is severe sepsis. Is the severe sepsis not responding to IV fluids? Not responding to IV fluids. There are certain modifications in these definitions. So see, according to 2016 criteria, what are the modifications of these definition? So this was the criteria in 2016. First, what is sepsis according to this criteria? So sepsis is the suspected or documented infection. Suspected or documented infection and acute increase in more than equal to 2 SOFA points. Acute increase in more than equal to 2 SOFA points. We discussed what is the full form of SOFA, sequential organ failure assessment. So it is the sequential organ failure assessment. After that, what is the definition of septic shock? According to this criteria, this is the suspected or documented infection. Suspected or documented infection plus vasopressure therapy. Vasopressure therapy needed to maintain vasopressure therapy needed to maintain mean arterial pressure more than equal to 65 mmHg. You have to remember the value. Mean arterial pressure more than equal to 65 mmHg and serum lactate more than 2 millimole per liter despite of adequate tissue perfusion. Despite of adequate fluid resuscitation. So serum lactate more than 2 millimole per liter despite of adequate fluid resuscitation. So this is the definition of septic shock. Nowadays questions are asked about multi-organ dysfunction syndrome. So what is multi-organ dysfunction syndrome? Have a look. MODS, in short, is known as MODS. Multi-organ dysfunction syndrome. So what is the definition? Is the simultaneous presence of physiologic dysfunction and or failure of two or more organs So this is the definition of multi-organ dysfunction syndrome. So these questions are frequently asked, especially systemic inflammatory response syndrome and multi-organ dysfunction syndrome. In most of the exams, this question was asked that what is the most important factor in preventing wound infection, and that is hand washing. So staff should wash the hand in between the two patients. So we are going to discuss prevention of wound infection. Prevention of wound infection. First question, what is the most important factor in prevention of wound infection? And that's hand washing. So staff as well as clinicians should wash their hands in between two patients. So whenever we have to attend one patient, after attending we should wash the hands. After that, hair removal prior to surgery. So there should be hair removal prior to surgery. There are various methods. What's the best method? It's the on-table clipping of hair, which is having least infection rate. So the best method is on-table clipping of hair. It's the on-table clipping of hair. After that, questions are asked that what are the various methods used for hair removal prior to surgery. So see, there is maximum infection rate. In which cases there is maximum infection rate? In shaving, followed by use of depilatory creams. Maximum risk of infection in shaving, followed by use of depilatory creams, followed by on-table clipping. So these are the questions which are asked. After the third method, that we have to use prophylactic antibiotics. So use of prophylactic antibiotics. This is the question which is asked many times. It is asked frequently that what is the best time to give prophylactic antibiotic? It's at the time of induction or at least 30 to 60 minutes before the incision or surgery. So best time It's at induction of anesthesia. So the best time is at induction of anesthesia or 30 minutes to 1 hour before surgery. 30 minutes to 1 hour before surgery. Now second question, suppose the surgery is prolonged. In prolonged surgery, after how much time it should be repeated? And the answer is after 4 hours. So next question, which is very important. In prolonged surgeries, repeat dose is given after 4 hours. Repeat dose after 4 hours. This is a question. So two questions which are frequently asked. First, best time to give the prophylactic antibiotic at induction of anesthesia or 30 minutes to 1 hour before surgery, and the repeat dose after 4 hours. After that, we have to go for cleaning of the part. That's cleaning of part. So generally, in general surgery, what? Abdominal operations are done, generally you have seen. And how we are going to clean? It's from nipple to mid-thigh. So cleaning of part, especially for abdominal surgeries, it's from nipple to mid-thigh. And if you have seen cleaning, how we are going to clean? If we are going to clean the abdominal part, you have seen that we are going to clean medial part first and then going to lateral. So in abdominal part, the swab moves medial to lateral, and in thigh, what? It moves lateral to medial. Why? Because the groin or perineum is the most infected part, and that should be covered at last. So how swab moves? Medial to lateral is the medial to lateral while cleaning abdomen. And it's lateral to medial while cleaning thighs. So these are the important questions related to cleaning of the part. After that, we have to maintain ideal OT parameters. So maintain ideal OT parameters. These are new questions which are being asked nowadays in exam. OT parameters. So first, what should be the ideal temperature? We have to maintain temperature. It should be 18 to 25 degrees centigrade. After that, what is the relative humidity? You have to remember, relative humidity is the 50 to 60%. After that, what about the positive pressure inside OT? Positive pressure inside the theater or inside the OT, it should be 2 mmHg above atmospheric pressure. 2 mmHg above atmospheric pressure. And inside OT, how many air exchanges should occur? Minimum 15 air exchanges per hour. So inside OT, 15 air exchanges per hour, and at least 4 should be fresh air. Out of these, at least 4 should be fresh air. And there should be ultra clean laminar flow inside the theater. Ultra clean laminar flow, laminar airflow inside the theater. So these are the OT parameters which should be maintained to prevent the infections. Nowadays, questions are being asked about OT zones and OT parameters. This is a new topic, but nowadays they are asking questions. So have a look of OT zones first. OT zones. There are 4 zones. First, what is zone 1? Zone 1 is the protective zone. Zone 1 is protective zone. So what is included in this protective zone? In this zone, we include reception, waiting, reception areas, waiting, trolley bags, and there are changing rooms for the staff. This is zone 1, that is protective zone. After that, there is zone 2. This is the clean zone. Zone 2, this is clean zone. In this clean zone, pre-operative room, that is included. There is recovery room, and there is plaster room or stores for various instruments and equipments. After that, zone 3. This zone 3 is sterile zone. This is the actual zone where surgery is being performed. So this is sterile zone. And most probably, this will be the question which will be asked in exam. So in this sterile zone, what is included? Obviously, operating room. So here we are going to include the operating room and scrub room. After that, zone 4. Zone 4 is disposable zone or disposal zone. So zone 4, this is disposal zone. And you know, in disposal zone, what happens after surgery? Waste is being thrown in this particular zone. So here, generally, waste is thrown here in disposal zone. So what is included here? Here you will find dirty utility, and there is disposal corridor. Disposal corridor. So these are the 4 zones of OT. Now see, the questions are asked in detail about OT parameters. So see, the questions related to OT parameters. First, there should be 15 to 25 theater air exchanges per hour. 15 to 25 theater air exchanges per hour in positive pressure ventilation system. In positive pressure ventilation system. First. Second, there should be ultra clean ventilation system. Ultra clean ventilation system. Here we are using HEPA filters. So use HEPA filters. What is HEPA? High efficiency particulate air. So the full form of HEPA is high efficiency particulate air filters. Second, remove 99.9% of particulate matter. Particulate matter more than 0.3 micron in diameter. Use laminar airflow. Use laminar airflow. And there should be air exchange every 2 to 3 minutes. Air exchange every 2 to 3 minutes. I discussed what temperature we should maintain, 18 to 25, and how much relative humidity, 50 to 60%. So temperature 18 to 25 degrees centigrade, and the relative humidity 50 to 60%. After that, question is asked about general lighting. The general lighting. So here the ratio of intensity, in this case, what is the ideal ratio of intensity of general room lighting to surgical site? It should not exceed 1 to 5. It should not exceed, be careful, should not exceed 1 to 5. So ratio of intensity of general room lighting to the surgical site should not exceed 1 to 5. Ideally, what should be the ratio? Ideally, the ratio should be 1:3. So this is ideal. Why? Otherwise, what happens? There is eye fatigue. So why it's done? To minimize eye fatigue. After that, operating area. Lighting of this operating area. The overhead light must be shadowless. Overhead light must be shadowless. And it should give 25,000 to 1,25,000 lux of light. So these are the questions, important questions related to OT parameters. Now see, this is WHO surgical safety checklist. It's the WHO surgical safety checklist. Clear? So now can you see, first, before induction of anesthesia, what sign in? Before skin incision, time out, and before patient leaves operating room, there is sign out. 3 components are there. We are going to discuss in detail one by one. So see here, before induction of anesthesia, what sign in? In that case, we have to confirm the patient identity, what is the site, what is the procedure, and whether consent has been taken or not. All these things should be checked. After that, site is marked or not, anesthesia safety checklist completed. Here we have to see pulse oximeter on patient and it's functioning or not. Then you have to check whether patient is having any allergy or not, whether patient is having difficult airway or there is risk of aspiration. If yes, then we have equipment or assistance available for the patient or not. Second, how much is the amount of blood loss? If it's more than 500 ml, or in children it's 7 ml per kg. What? If yes, then adequate IV access and fluids are planned. After that, before skin incision, that is timeout, confirm all team members have introduced themselves by name and role. Next, surgeon, anesthesia professional, nurse will verbally confirm patient, site and procedure. After that, what are the anticipated critical events? Surgeon reviews what are the critical or unexpected steps, operative duration, anticipated blood loss. Anesthesia team reviews, are there any patient specific concerns? And what is the nursing team reviews? Has sterility has been confirmed, or is there any equipment which is not functioning properly, having some kind of problem? Now the most important, which is generally asked in exam, has antibiotic prophylaxis given within last 60 minutes? We just discussed that the antibiotic prophylaxis should be given at the induction of anesthesia or at least 30 to 60 minutes before surgery. And is essential imaging displayed or not? Now third is before patient leaves operating room, that is sign out. So here the nurse verbally confirms with the team that what's the name of procedure recorded? 1. After that, most important aspect, instrument, sponge, needle counts are correct or not. Then specimen is labeled including the patient's name and whether there was any equipment which was having some kind of problem during surgery. After that, surgeon, anesthesia professional, nurse review the key concern for recovery and management of this patient. So these are the important points. These are the highlights of WHO surgical safety checklist. Nowadays, questions are asked about causes of post-operative fever according to the days. So see, what are the causes of post-operative fever? So causes of post-operative fever. On post-operative day 1 to 2, what's the most common cause of fever? And that is atelectasis. It's the atelectasis. This question was asked many times. After that, post-operative day 2 to 3, what is the most common cause of fever? This is UTI, that is urinary tract infection, and we discussed UTI is the most common hospital acquired infection. After that, post-operative day 3 to 7, and it's the wound infection. And I also told you what's the other name of this wound infection. It's known as surgical site infection. So fever on 3rd to 7th post-operative day. After that, post-operative day 5 to 7, it's because of DVT or thrombophlebitis, deep venous thrombosis or thrombophlebitis. And post-operative day more than 7, so after 7 days, it's the drug fever. These are important questions related to causes of post-operative fever. Next important topic is wound dehiscence. So you can see, what is this wound dehiscence? So this wound dehiscence can be partial or it can be total. Second, after dehiscence, if there is extrusion of viscera also, it is known as evisceration. Question is also asked, what is the other name of wound dehiscence? It is also known as burst abdomen. So what's the other name of wound dehiscence? It's also known as burst abdomen. Question. The question is asked, what's the first sign of wound dehiscence? If you have seen this in the word, is the serous or serosanguinous discharge from the wound. So there is pink color discharge, that is also known as salmon fluid sign. So it's the serous or serosanguinous discharge. Serosanguinous discharge from the wound. And this is also known as salmon fluid sign. Salmon fluid sign. So we discussed what are the types. It is of two types, partial or total. It's partial or total. And after total disruption, if there is extrusion of abdominal viscera, this is also known as evisceration. So what is this evisceration? It's the extrusion of abdominal viscera. After disruption of all the layers. After disruption of all the layers of abdomen. Question is asked, generally on which post-operative day wound dehiscence or burst abdomen is seen? It generally occurs on 5th to 8th post-operative day. So wound dehiscence usually occurs on 5th to 8th post-operative day. Questions are asked, what are the predisposing factors? And I told you, generally in similar situations, two predisposing factors are, one is diabetes mellitus and one is immunocompromised state. After that, there are local risk factors and there are systemic risk factors. So have a look. Predisposing factors. It is further divided into two categories. One is local and the second is systemic. Local: inadequate closure, midline vertical incisions, increased intra-abdominal pressure, and there is deficient wound healing. Due to sometimes what happens, there is infection, there is hematoma, there is seroma, and if there is presence of drain also, this also increase the risk of infection. So there is presence of hematoma, there is seroma, or there is infection. Drain also increases the risk. So presence of drain. Simple. After that, what are the systemic factors? I told you: diabetes mellitus, immunocompromised state, there is uremia, there is jaundice. So these are the systemic factors which impairs the wound healing and it leads to burst abdomen. Now how we are going to manage the wound dehiscence or burst abdomen? So first of all, if there is wound dehiscence without evisceration, we have to go for elective closure. So if there is wound dehiscence without evisceration, in these cases we go for prompt elective closure. And if there is evisceration, with evisceration means there is extrusion of viscera. So in these cases, first we have to cover the extruded bowel with moist towel. So wound covered with moist towel. Exposed bowel is rinsed with ringer lactate containing antibiotics, and return to abdomen. And in these cases, how we are going to close the abdomen? Here, the wound is closed by tension suturing. So wound is closed by tension suturing. Now here you can see how we are going to perform the tension suturing whenever there is wound dehiscence with evisceration. So this is the management of wound dehiscence or burst abdomen.